This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon. It's a pleasure to have you all with us for another deep dive into the literature that shapes our clinical practice.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Neurosurgical Review, published in 2026, titled MIB-1 Index Predicts Low Recurrence Risk After Subtotal Resection of Meningiomas, a retrospective study of 505 patients. It comes out of a Helsinki University hospital and deals with a question we face every single week in the clinic. How do we predict which meningiomas are going to come back, especially when we can't get a gross total resection?
This is a perennial challenge, Alara. We know meningiomas are the most common primary intracranial tumors in adults, and while we often call them benign, they show substantial variability in growth and recurrence. The World Health Organization histological grading system is our gold standard, but its prognostic accuracy, particularly for WHO Grade 1 tumors, has its limits.
Exactly. And that's where the K67 MIB-1 index comes in. It's a biomarker of cellular proliferation. The authors, Lejeva and colleagues, pointed out that while MIB-1 is already used for specific thresholds in gliomas, we haven't had a universally accepted threshold for meningiomas. Some institutions use 3%, others 5%.
I remember a U.S. study mentioned in this paper that suggested a 4.1% cutoff for 10-year recurrence-free survival. This Helsinki study really wanted to validate that and see if a 4% threshold could help us individualize follow-up.
Let's look at the cohort. It's a large retrospective study, 505 patients operated on between 2005 and 2018. They had a median age of 59, and as we'd expect, about 67% were female. What's impressive is that every single patient had at least 5 years of clinical and radiological follow-up.
That 5-year minimum is crucial. Meningiomas are slow growers. A 2-year follow-up doesn't tell the whole story. Now, they included all WHO grades, but the majority were Grade 1 and Grade 2, right?
Correct. About 55.8% were Grade 1 and 41.6% were Grade 2. They also standardized the MIB-1 index. Since these tumors can be heterogeneous, pathologists often report a range, like 10 to 12%. The researchers used the midpoint of that range for their analysis.
Before we get to the results, let's talk about the extent of resection. They used EANO guidelines, gross total resection versus subtotal resection based on the first postoperative MRI. Interestingly, they mentioned they don't use the Simpson grading scale systematically at their hospital.
Right. They noted the criticism regarding Simpson's subjectivity in the modern era of neurosurgery. For their purposes, GTR meant no residual tumor on MRI, and everything else was STR.
So let's get into the meat of the study. What happened to those patients where we left a little bit of tumor behind, the STR group?
This is the most impactful part of the paper. They looked at 58 cases of subtotally resected WHO Grade 1 meningiomas. Overall, 36% of those, 21 patients, recurred within 5 years. That's a significant number. But when they applied the MIB-1 threshold of 4%, the picture changed dramatically.
Tell us the numbers for the low MIB-1 group.
Among the 35 patients with an STR Grade 1 meningioma and an MIB-1 index of 4% or less, only 4 patients recurred. That's only 11% in 5 years.
That's a powerful finding. If I have a Grade 1 meningioma where I had to leave a small remnant to protect a cranial nerve or a vessel, and the pathologist tells me the MIB-1 is 2 or 3%, I can breathe a little easier. On the flip side, what about the multivariable analysis? Did MIB-1 hold up against other factors?
It did. In the multivariable analysis, 2 things remained significant for 5-year recurrence. First was the preoperative meningioma volume. The risk increased by a hazard ratio of 1.02 per every 1 cubic centimeter increase. The second was the 4% MIB-1 cutoff, which had a hazard ratio of 3.9.
A hazard ratio of nearly 4 is quite robust. It really suggests that the biological engine of the tumor, its proliferative capacity, is just as important, if not more important, than the sheer volume we see on the initial scan.
They also looked at the presumed embryological origin, distinguishing between neural crest and mesoderm-derived tumors, as prior studies suggested this correlates with molecular profiles and mitotic activity. However, the main takeaway for the residents and surgeons listening is the utility of that 4% threshold in designing follow-up.
Let's talk about that clinical application. For a Grade 1 tumor with a low MIB-1, especially after a subtotal resection, the authors are suggesting we could move towards less frequent imaging.
Exactly. They argue that MIB-1 offers utility particularly because molecular genetics aren't routinely defined for Grade 1 meningiomas. While we might do extensive genetic profiling for Grade 2 or 3, Grade 1 is often the wait-and-see group. This 4% cutoff gives us a risk-adapted strategy.
It's about cost-effectiveness and patient anxiety, too. If we know the risk of recurrence is only 11% over 5 years despite a subtotal resection, maybe we don't need an MRI every 12 months for a decade.
The study also points out that while WHO grade 1 is generally benign, its prognostic accuracy for recurrence is limited. By using the MIB-1 index, which is already a part of routine pathological assessment, we aren't adding any cost to the diagnostic process. We're just using the data better.
Now, for the residents listening, what were the specific inclusions again? This was primary resection only, right?
Yes, adult patients, primary resection, no prior surgery or radiation for that tumor. They treated each meningioma as an independent case even in patients with multiple tumors.
It's interesting that preoperative volume was such a significant factor as well. It reminds us that larger tumors at presentation might have a different biological trajectory, or perhaps simply a higher statistical likelihood of having residual cells even in a perceived GTR.
And we should note that their median age was 59, which is very representative of the typical meningioma population. The fact that the 4% cutoff held up so well across 505 patients gives it a lot of weight.
To summarize for our listeners, in this large retrospective cohort, the MIB-1 index of 4% proved to be a significant predictor of recurrence. Specifically for WHO grade 1 meningiomas that undergo subtotal resection, an MIB-1 of 4% or less identifies a subgroup with a very low, around 11%, risk of recurrence within 5 years.
It really highlights that subtotal resection isn't a single category. An STR with an MIB-1 of 2% is a very different clinical entity than an STR with an MIB-1 of 8%.
Precisely. This study by Lejeva and the Helsinki group provides us with an empirical basis to tailor our post-operative imaging strategies. It moves us away from a one-size-fits-all follow-up and towards a more individualized, evidence-based neurosurgical practice.
It's a great example of how a common, routine biomarker can still provide new insights when looked at through the lens of a large, well-followed patient cohort.
Well, that's all the time we have for today's episode. I want to thank Dr. Alara for breaking down the data with me.
Thank you, Dr. Aris. It was a pleasure.
And thank you to our listeners. Keep an eye on that MIB-1 index in your next pathology report. We'll see you next time on the Neurosurgery Hub podcast.